Yeah, on the majority part of the question, I like to concur with Edwin because the key point here is this child, from the question I've read, this child developed these symptoms mostly after weaning off, which means that the moment this child aliachishwa the breast, she aliacha the baby stopped getting the proteins from the milk. Now that the baby was weaned to porridge, which porridge is a more of a carbohydrate diet, so kumekuwa na loss of a lot of protein, which on the majority part of the question brought the symptoms of the lack of proteins, to things to do with the edema, weight loss, and something like that. But and then interestingly, on the lower part of the question, anakuja kuwa na some other symptoms like diarrhea and a heart rate of 126, which point more of a infectious thing, respiratory of 40, pia ina point towards respiratory infection, and a capillary fill of more than 3, also dehydration. So I'm not really sure of the diagnosis here, but I'll concur with Edwin on the majority part of the question, protein energy malnutrition. But again, some huwa inakuwa ina cover almost all these nutritious diseases, talk of kwashiorkor and marasmus. The severe acute malnutrition huwa ina cover both of them. So huwa ina cover the protein lack part and the carbohydrate part combined with other aspects. So malnutrition will let all the problems, but the major problem ilikuja due to lack of proteins. I'm
Thank you
done
for
here.
that input. Thank you. I don't know what others. You're not even chatting in the chat box. So I don't know what's your. Yes, Imela Damaris. Brenda said diagnosis severe dehydration, stroke kwashiorkor. Yes, Imela.
Okay, for me, I'll go with the complicated severe acute malnutrition. Yeah, I think people have already given the reasons why they're rooting for severe acute malnutrition. So mine, considering the duration of 3 weeks, yeah, I'll go for severe. Now, no, complicated. Yeah, so it will be complicated severe acute malnutrition for me.
Complicated. Ish. New diagnosis in town. Okay, thank you. So we have Imela saying complicated, we have Millicent saying some, we have Edwin saying protein energy protein malnutrition, protein energy malnutrition. We have Brenda saying there kwashiorkor, severe diarrhea, not talking about hypovolemic. So we have multiple answers. Dory is supporting Imela, complicated. For me, with the Newton, you have not tried. There are some other people who have not given their diagnosis, so we don't know where you are. Are you standing on the fence? Don't stand on the fence kindly. Let us know. Aline, yeah? Harriet, the consultant pediatrician. Just give us your diagnosis. We are chasing time. But here and you support your diagnosis before we try and give us. I think just take Millicent is consistently sticking to her answer. If you combine all those input, diagnosis is some and border carrying all of them. Complicated severe acute malnutrition with kwashiorkor, that's mine. Thank you, Dory. And I think when you talk about complicated sum, thank you. Yes, Brenda Cross.
The reason why I'm saying kwashiorkor is when you look at the primary causes of kwashiorkor, ya kwanza ni faulty weaning, mostly on starch or carbohydrate food. Ya pili ni a depressed child. mostly when the second child is born, like the parent and shift attention to the younger child. So it's mostly inashika a child who is like when a second child is born, like there's a younger child and the parent and shift attention to her. So from our question, the child, he was weaned abruptly at 2 months ago, and also the mother is pregnant. This means that, like, this is just kwashoko, because when we say protein energy malnutrition, we are combining kwashoko and marasmus and also nutritional edema. So to narrow it down very well, it's kwashoko with severe dehydration.
Thank you. But guys, all these things you're talking about, kwashoko, protein, energy, I think all of them will still fall under malnutrition. And the question is asking us to classify. But for the definitive diagnosis, I think all of you might be right in one or the other. But for the general diagnosis here is SAM, complicated SAM. That's the general diagnosis. What you should know is how to classify SAM depending on the Z-score and also depending on the MWAC and the other clinical features that suggest that SAM indeed is there. So I'm saying complicated because of kwashoko and also talking about irritability. Maybe it's complicated with infection and other things. And then the differentials is all of those things that you have talked about. They might be there. Even heart failure. You can say heart failure is a differential, pitting edema. Alvin Okumu, you have something? Go on.
Mazungu, I need
Yes.
guidance before you continue and make a conclusion here.
Yeah.
Because I don't really know the definition of SAM. Because as far as I know, SAM, tukiongea SAM hata tukiongea management, kuna the 10 steps of management of SAM. So we all address those issues because those issues are the ones that bring about SAM. Because tukisema we have SAM and a differential of dehydration, tunajicontradict. Definitely tukiona mtoto mwenye akona hypothermia, hypoglycemia, dehydrated, we are talking about this child akona SAM. There's a malnutrition. And then we know kuna other forms, different forms of malnutrition. Hata since primary tulikuwa tunasoma the likes of marasmus, kwashako, ama sijui kwa rickets, those deficiencies za nutrition deficiencies. Tulikuwa na hizo diseases. Now, when it comes to some uzi combine, itseme ni kama occurrence of most of these things at the same time. We are talking a child mwenye ako hypoglycemic, hypothermic, ako na infections, dehydrated at the same time. That's why tunasema mtoto ako na SAM, because from the management principles tuna addressing those things. We don't treat as independent. Tunasema tumeachieve management of SAM when to treat every complication. I'm not sure, but I need your guidance.
So try to get you. So you actually need guidance on the diagnosis, specificity, or because you have talked about many things from primary. You learned about kwashoko differently. But when you are talking about SAM, all those things are combined there. Because all of them, remember, it's resulting because of nutrition, either deficiency or excess. I said when I started, I said there is undernutrition and over. There is that over. Is it over or the opposite of undernutrition? All of them. When you talk of undernutrition, like in protein, when you're talking about that protein deficiency, that is undernutrition. This person is not taking protein. You are relating it to milk because the child stopped taking milk. So that will be under undernutrition, and it falls under malnutrition. Now, malnutrition is further classified into SAM and MAM.
And
So
mom,
it's
yeah,
an
true.
umbrella. Yeah, it's an umbrella. It's SAM, MAM, and the other one is there the other one? Severe,
Ni
moderate.
moderate and severe too. I don't think, I'm not sure if kuna mild, but I know of moderate and severe.
Yeah, they're too common. So actually malnutrition is an umbrella that covers all of those. So an umbrella of malnutrition divided into SAM and MAM, and then under SAM we'll have those complications. Of course, kwashiorkor is inside there. There is
Yeah.
protein energy. That what you are talking about, the protein problem. That one that's just because of protein only. And remember, even this kwashiorkor is more of protein. That's why there is a lot of edema. You get the pathophysiology of protein resulting to edema and so on. So if you see wasting, you think of marasmus. If you see of that edema mostly, you think of kwashiorkor. Pot belly, used to learn in class 4 there, I remember. Pot belly was one of the classification of marasmus. And in not marasmus, I mean kwashiorkor. And in some cases, we do have marasquash. Both of them are presenting at the same time. Marasquash. It's called marasquash. It can present both of them at the same time. So I think are we at a go so that we can make a move? You can react. Yeah, somebody has Newton has illustrated the welcome classification. We thought it never existed. So you can see there kwashiorkor, edema present, plus weight loss, weight expected for age, loss by 60 to 80%. And then marasmatic kwashiorkor, if less than 60% plus edema, but here it is kwashiorkor. WHS Z score, they're talking about that. You need to know some. I talked of mark less than 11.5. That one, it was 11, so meaning that one clearly indicates some, and also mostly edema plus 3, and weight loss, the Z score. So the Z score, the edema, the MWAC mostly will be able to let you know that it is some. The three exist in combination. The Z score, the edema, and the weight, the edema and the MWAC. And then also meet complicated some because hypothermia, diarrhea. Was it hypothermia? It was the temperature was 30. Somebody to classify in the chat
35.8.
box. Is it hypothermia?
35. Yeah,
It is hypothermia.
yeah, it was 35.8.
Yeah, then I'm asking, is it hypothermia?
No.
What did the protocol? What was I reading from the protocol?
35.5. But it's on the
35.5.
lower level.
Oh, it is low on the lower level. Okay, noted. It's on the lower level. So with those, all those things that are presented, that's the welcome classification is just trying to illustrate for us some and kwashiorkor, whatever we have been discussing. But what is common in the NMCI, you need to classify SAM and MAM and be able to give your diagnosis. Now, we are doing well. Let us be able to be active. Time is catching up with us, but it's better than never. List 4 other clinical features you will look for on full examination to support your classification. That one I want us to mention haraka in the chat box, and also those who are ready, you can just mute off and mention to support that diagnosis you have talked about. But we have mentioned most of them. Which other things will you look on full examination? We have been told about the edema, the hair is lost. You've been told about the temperature, the pitting, the hair is thin, reddish, easily practicable, dark patches peeling off the groins on the buttock, child is irritable, miserable, not playing, mother said watery diarrhea. Actually, they on examination, they check for the dehydration. You can check for those dehydration. Now, how do we check? Brenda, dehydration. What will you examine? And you add another some points there. Brenda, are you ready? If not ready, you can get Aline. Aline. Aline,
Okay,
are you there? Yes. Who is ready?
okay, I think utaangalia mambo na hizo skin pinch venye inarudi, sunken eyes, hizo dry mouth ama dry lips, vitu tu kama hizo kwa dehydration.
Thank you. Somebody was talking about anterior fontanelle closes at 18 months. And now we are at 18 months, so we don't know whether it has closed or it is still waiting for 18 months to end so that it can close. But that's a good note from Alvin. It closes at 18 months. What about the posterior fontanelle? You can chat there. When does it close? And then you can check even for the head circumference. Yeah, you know, thinking like hydrocephalus is a complication. Another things that you can check for is what? You can check for, have they checked for pallor? They have checked, yeah, for capillary refill. Which other things can you brainstorm? Which other things do you think they have not checked for? I've
I
seen
think
you
you'll
many
also
times.
you'll
Yes.
see us on the neurological status of the baby.
Yeah, very good. You do what we call AVPU. That is alert. A is alert. P is response. V is verbal. P is pain, response to pain. Then U is unresponsiveness. So if you do AVPU, not GCS, here you do AVPU, you say AVPU at A, that child is alert. If you say AVPU at U, the child is unresponsive. If you say AVPU at V, the child is responsive to verbal, but not alert. Thank you. You'll check for that. I think, have we exhausted? Yes. For other clinical, I think we have mentioned. The other features you need to check. You can check, you know, when you're doing parabdomen examination, you check for ganomegaly, you know, you check the liver, is it enlarged? That's, you check for the distension of the abdomen, you know, that is also a feature. Ascites.
Na pia
Hello, yes.
sorry, additional that pia utacheck the ribs,
Check for,
hizo kama kuna prominent ribs
yeah,
huwa zinaonekana kwa marasmus.
yeah, mara squash. You can check for the tones, the hands, the movement. How is the power? The musculoskeletal system, you know, you check for the power. Tone, if there is no loss of tone, like in hypoglycemia, the tone, there is hypotonia, like hypotonia. The child is weak generally. Also, wasting pallor, moon face. Thank you. Those are enough. This child has diarrhea and hypothermia. Outline your immediate emergency management. Yes, we go on. Diarrhea. The child has diarrhea. Actually, we are told 5 episodes, 5 times a day for 4 days. After checking the hydration, for instance, you find that because you are not being told about the rehydration status, after you check for the hydration, you found that the child is in shock. Now, management, immediate management.
Okay, fluids.
Yes. Go on. How do you give fluid in shock?
I think
Start.
means bring up to state. Okay, yes. I'm not not sure.
Potea hatuja.
Okay, nasema 20 meals bring us lactate. Sijui per kg, I'm not sure.
You must be sure because COC is coming. 20 meals per kg.
Okay. Yeah, for 15
And then
minutes. Boilers.
for 15
Yeah, then
minutes.
for 15 minutes. Then you
Then
proceed to plan C.
before
Yeah.
proceeding, if you have given that 20 meals per kg for 15 minutes, then the child is still in shock. What do you do?
Another one, you repeat the bolus.
Thank you. I see that I saw that question in one of the COC questions. After giving that, what do you do? You repeat the bolus as you assess for rehydration and classify again. That is for shock. Then you go for plan C. Plan C, what does it say? We are still on Imela before we go to another person to tell about Savia.
It's okay. So, according to plan C, that's where you give 100 meals per kg, and it's divided into 30 meals. Okay, for kids less than 1 year, you give 30 meals per kg for 1 hour, then the next 70 meals per kg for 5 hours. Then for kids more than 1 year, you give 30 meals per kg for 30 minutes. Yeah, then 70 meals per kg for 2.5 hours. Yes, that's
Thank you.
what plans.
So plan C, we have plan C one, A and B. Or plan C1 and okay, you'll screenshot the protocol on that.
Kuna plan C step 1 and plan C step 2. Hivyo ndio
Yeah,
alikuwa
that's
akisema.
why. Yeah, that's why I was concerned because he started about 30 minutes, then he talked about 75. Thank you for that. Now we go for Savia. Asman said, you have accessed that child we are talking about. Then you realize that you have classified your rehydration as severe. How will you go on that? Asman, did you get me? It seems he's not able to get us, but
Yes, I can get you.
yes.
Yeah. So basically, you're asking about the management of severe dehydration in children.
Yes.
Okay. So without severe acute malnutrition or with malnutrition?
With severe acute malnutrition. Because actually our case is on malnutrition. Now you have assessed the dehydration, it is severe.
Okay. I think rehydration we give 100 ml per kg of RL. RL is usually preferred, or sometimes normal saline if RL not available. But RL is usually the fluid of choice. Then I think it also goes with the age. I think kuna hiyo ya less than 12 months, then more than 12 months.
Thank you. But you started very well. You know, when you check on the protocol on malnutrition, because this is not only severe dehydration alone without now with malnutrition, we are being advised there that if it is check dehydration, if has diarrhea, if in shock, use IV fluid as we have used. If not in shock, if this it's other things not in shock, you use Risomol. But now, how do you even prescribe this Risomol. That is what the protocol says. So meaning in shock is the only one we use fluid, and then in this other dehydration, you use Risomol. So somebody to get us the prescription of Risomol.
Think iko presented hapo kwa screen.
Yes.
Iko presented hapo kwa screen ama?
Yeah. Thank you, Newton. First 2 hours. Ish. Okay, talking about ABCD, keep warm. Hypoglycemia, we talked about RBS. You give dextrose. It is 5 ml per kg, 10% dextrose. If no glucometer, you just access the chart for hypoglycemia and give. Hypothermia, you rewarm. We talked about that one. Do not give IV bolus unless shock. Assess. If some dehydration, give Risomol. 5 ml per kg in 30 minutes for 2 hours orally or through the NG. If shock, 15 ml per kg IV Risomol. But the other protocol is talking about we are at home. 75 ml per kg Resomol, and then in 1 hour, then you alternate Alvin or Kumo interjection or addition.
Answering the question ama you just brought in something to do with dehydration into our question, because the question ilikuwa inasema the immediate management of the child, because nashangaa we are addressing dehydration na ABCD, hata you're not sure if the child is breathing. So sijui tunafanya aje ama tunajibu nini?
No, I think you can get the Newton has stopped presenting. The question was
So you intentionally skip that part of initial management ya child, tuanze na ABCD approach, then we go 10 steps, because inaanza vizuri na correction of hypoglycemia, because before even you get to dehydration, you have to sure tunaenda stepwise.
let me get to the question. I'm not opening the question. I'm not able to. Let me open the question on my side. It was talking about immediate. Can you be able to read that question?
The question, Newton, can you project hiyo hapo kwa swali, because niliona something, what the child has diarrhea and something, what's your immediate management in the first 2 hours of admission or something like that? Yeah, the child has diarrhea and hypothermia. Outline your immediate emergency management in the first 2 hours following the 10 steps of WHO.
Yeah, diarrhea and hypothermia. So what do you think is the management? Of course, the
Immediate,
ABCD. We forgot the
yeah.
ABCD. Yeah, your point was we forgot the ABCD, but now the immediate emergency management in the first 2 hours. Yeah, you cannot manage that diarrhea without classifying. That's why we went to classification, or we just manage.
We
You must
classify when
classify.
we want to classify come to apumui.
Already when you are taking the history, you classify it. So mostly not on examination, because you are not given on the history, on the case, you are not given about the dehydration status. So on examination, on further examination, you're able to examine and know, so that when you're managing the diarrhea, or is there any other way you manage the diarrhea?
Buka, my point is,
Yes.
we are answering this question to get the marks and to impress the examiner. So what I mean ni, kwa hizi swali zinaanza na immediate emergency management, the first 2 hours, we are starting with stabilizing the child first. That is the ABCD up. And then we do the 10 steps now. By correcting what kills the child first. Because I believe those 10 steps in evil based on what kills the child.
I've just realized that I did not read the whole question. I just read immediate. Oh, I didn't finish. It's only I'm seeing the second line. In the first 2 hours following the 10 steps. Oh, I didn't see that. I'm very sorry. The 10 steps. That's why I was focusing. We were supposed just to outline the 10 steps. That is what is needed. There, you don't need to answer what you're answering. You need to go on the 10 steps accordingly. Now, I think we are all there. The 10 steps must be in some order, isn't it? It should not we cannot start with giving antibiotic. It must be in some order. As Alvin has said, number 1, we start with ABCD. Now, which one follows? You can list them in the chat box, or somebody can pick up the mic and give us the first 4. Chap chap, hii ni kitu tushapitia. You want to close up. Dori, umelala? Pick up the 10 steps of WHO, then we want to go to investigation, then the baseline. Somebody to prepare. I think Edwin Okinyi give us one investigation and reason. You prepare on that. Another person also. Brenda is still in the house. Aline, you have not talked. Millicent, you give us another investigation and rationale. We go on. Dori Cherop.
Sawa, so I'll just mention the first 5 and then mtu mwingine atashika basi ndio kila mtu aongee. So in the 10 steps of management for malnutrition, tuko na the correcting hypothermia. So you'll want to cover this child with either blankets, kama ako on any IV fluids, you'll make sure that the nini is warm, and then pia hapo hivi kwa the room, make sure there is heaters. And then the next step is dehydration. Of course, kwa hizo utatafuta words za kuandika vizuri so that the examiner mark vizuri. So the next step is correcting dehydration. And I think tumeisema hapo hivi, nani ameongelelea tu sahihi kutumia resomol, that is 7.5, if I had right, 7.5 mils per kg over 1 hour, and then una introduce 7.5 7.5 hiyo nini F75 I mean, and then una alternate. And then pia hapo kwa dehydration there's something else. If at all you did the full hemogram ukapata that ako na low HB and kuna need ya kutransfuse blood, then you will transfuse blood. Inakwanga ngapi? Nimesahau kidogo. And then of course you'll give Lasix because of the fluid overload or something. And then pia so we go to the fourth. I hope sijaacha anything hapo ya nini, sijaacha anything hapo. So the fourth ni electrolyte. Hadi niandike haki ndo nijue venye zinapatananga. So in electrolyte maybe kuna hii oral potassium. And then the fifth one is infection. So wanaanzanga na Genta 5 days, and then ikikuwa sawa you go to amoxicillin for 48 hours, and then mebendazole, that is after 7 days of finishing those. And then you check other infections kama kuna infection of the eye, you'll give eye, the ears pia in appropriate nini kama tetracycline hivyo. And then maybe kwanza hapo mimi nitaachia hapo hivi mpaka niandike chini ndo nijue venye zile zinafuatananga. Kuna venye sijui micronutrients nini mtu atanisaidia. So kuna swali maybe nilipatana na mahali about him, why is it that in dehydration ya some tunapeana Resomol and not IV kama Ringas lactate, normal saline? It's because Resomol iko na less sodium na iko na more potassium na iko na more sugars. I hope I'm clear. Na iko na more sugars and carbohydrates, and that's what we need for this case. Yeah, so giving RL ni kama tu kuongezea ni kama tu kuongeza fluid peke yake, but Resomol will cover most things that we need in this patient. Yeah, I think that is it. Mtu anaweza shikilia from hapo.
Dori, can I hebu nikusumbue if I can ask something, you know, umeongelea hiyo part. Kuna we have these two, I don't know if they are contradicting situations. We have this child is probably dehydrated, yes. At the same time, the child has edema. We know with dehydration, utakuwa na low urine output. And then at the same time, akona edema, you want to give Lasix. As far as I know, Lasix will work by increasing urine output. Sijui how does it work, because already tukona dehydration, you want to get out more urine. You are getting out a lot of fluids, at the same time we need fluids.
So kitu nilisoma is that I don't know, but kitu nilisoma is that we only give furosemide when kuna blood transfusion, not just because of the fluid overload or something, or kama eti juu akona what am I saying? Yeah, because of the blood transfusion.
Okay, got it.
Sasa mwingine ashikilie kwanzia hapo namba 6 ama yeah.
Edwin akona something to say.
Yes, I just wanted to add on what Doria said, that we only give furosemide in cases of blood transfusion. Why? You see, the edema in this particular patient is just due to lack of proteins in the blood, and not just because there is, so the proteins, maybe the lack of albumin is the reason why this fluid is now going into the interstitial spaces. So when you transfuse blood, you're already giving them protein through that particular path, but the fluid that is already interstitial space, when you are adding more fluids, you are Rudy, that one will be lost that way. Again, there's a part that I wanted to add hapo kwa shock. There's a patient that anaweza kuja, when you do ECG or you assess, unajua edema can be a sign of heart failure as well. So the normal dosage ya kutransfuse mtoto ni 10 mils per kg of whole blood, but kama ako in shock, protocol inasema unapeana nusu yake, which is 5 mils per kg of packed red blood cells over 3 hours.
Then nikiendelea from pali nani alikuwa ameacha Dori, I think alikuwa ametaja hypoglycemia, tuna correct hypoglycemia, tuna correct hypothermia, tuna correct dehydration, tuna correct electrolyte imbalance, of which hiyo tutatumia the F75. Then tunaanzisha fanya nini, tuna prevent infection ama tuna treat infection using expengentamizin. From that point tunaenda kwa correct micronutrients. So micronutrients, kama in case uko setup yenye hakuna hiyo F75 na F100, ndio utaenda kwa hii stage, but kama uko na hizo F75, there's no need of correcting micronutrients because already hiyo F75 ita take care of hizo micronutrients zingine. But in case uko kwa setup yenye ziko, you'll give vitamin A per oral. This one you'll give if there are eye signs of vitamin A deficiency, of which Manzungu anatuambia hapo kwa chat box signs of vitamin A deficiency. Na hiyo utaangalia kwa day 2 na day 14. Then utapeana multivitamins, utapeana folic acid 2.5 mg, but unajua tunajuanga ya wamama unapeana folic acid daily ile ya pregnancy. Sasa kwa watoto utakuwa unapeana on alternate days, akikula leo kesho akuli. Then kama mtoto ameanza kugain weight, unaweza anza kumpea tena iron supplements, but kumbuka tulishamtransfuse huko juu, so pia unakuwa careful. So hiyo ni correct micronutrients. Then I don't know, inakuwa number 7, sijui ni hapo ndo unaanza feeding ama okay. Now you prescribe feeding, you start feeding. Then number 8 na 7 zinanichanganya. Kuna ingine start feeding, kuna ingine inasema catch up feeding. Mtu ani confirmia na thumbs up kama ni hiyo,
I
ama
think
mtu
even
anisaidie.
the 7 ndo cautious feeding and then hiyo 8 ndo hiyo ni umesema catch up.
Oh, mtu anaweza tuambia the difference between catch up feeding na cautious feeding?
Edwin, acha ni kuinterject kidogo. Number 7 I think ni start cautious feeding. Hapa ndio tunaanza na you start with F75 then F100 kwa cautious feeding. Already kumbuka F75 at first tulitumia pale kwa electrolyte imbalance or something, and then now when you're starting cautious feeding you're not giving this child high protein, kutakuwa na refeeding syndrome. Kuna something called refeeding syndrome. So unaanza na food content yenye kuna low calories and low protein, that is F75, and then after umeachieve that then you go to F100, and then point number 8 ndio tunaenda na achieve catch up growth. Now this one sasa unaanza ku monitor the weight and stuff, kuona kama kuna some growth ama kuna changes kwa weight. Yeah.
Sawa, I think thank you very much Alvin. Mi hapo wise inani confuse, but now umeclarify vizuri. Then number 9 inakuanga sensory stimulation. Hii ndio sasa unaanza kumpatia TV vitu za kucheza cheza hapo hivyo. Then number 10 sasa ni discharge, then follow up and monitor kama ako nyumbani. Manzungu.
Asante sana. That is well done. I remember during the assessment I was given that question. Nilifika tu hapo 7 akili kama inasimama. But I thank God we were done. The same way we are going to be done with our COC. So we are doing well on investigation. On investigation, I want you to mention. Yes, there's a question. At what point do we discharge this child and declare him? Yeah, according to that, on discharge, Like when when you started on feeding, following up those steps, when you reach there on feeding, after start F75, then you stabilize the child. F100, after the child has stabilized, then the child will gain appetite. Because you only start F100 after the child has passed the appetite tests. Then F100, and then the child is now stable, the child is gaining weight, edema imeisha, the child now looks clinically stable. And then the HB is well, there is no signs of infection, those complications imeisha. The child anaweza nyonya. You just actually, Alvin, what you do is you examine the child for clinical. Is the child clinically stable for discharge? You don't discharge a child home, the child cannot still breastfeed, the child is still vomiting, the child has diarrhea. The same thing that the child came to the hospital with. So you only discharge when this child now has, at least you have seen a change from the start when the child came with those all signs. Now those signs have sublimed and the child is okay for discharge. And then Edwin talked about counseling. You do that. Now, that is well put it. I want us to rush through the investigation. Nilipea nani assignment? Investigation. I can take you through the first one. The first investigation. Edwin Okinye, yes. You just be brief.
Sorry, I thought ulikuwa umenipea hiyo investigation, but endelea.
You can let me give the first one, then you continue. Number one, you do RBS, BS for MPS, light for malaria. That one is very important. Normal, like you are in Nyanza region, you are in Western. But RBS, just do RBS. But what if you are in Mount Kenya? Will you do that RBS? But RBS is one of the mandatory investigation you need to do here, because the child is vomiting, the child is lethargy, so you might not know, it might be malaria or accompanying severe acute malnutrition. Now, Edwin, which second investigation?
Daktari, I'm confused. Is it MPS, BS for MPS, or it is RBS?
Oh, sorry, BS for MPS. I've only mentioned for malaria.
Okay,
Thank you for that correction.
So thank you very much. So other investigation already, kuna hizo initial investigation mtu alikuwa ashafanya kama RBS. Then daktari amesema BS for MPS ya malaria in case you are in Nyanza. Another thing you can do for a child like this, for you to able to appreciate if there is electrolyte imbalance, you need to monitor urine output. So you'll also, this one calls for UECs. You need to check on the UECs as well. Then this child is likely to go into hypovolemic shock and maybe, let's say, heart failure. You want to do, you want to check on the cardiac function. Maybe you'll do an ECG as well as a part of the investigation. But this one now you can do when you suspect that this thing could be heart failure. Then because the child is diarrheaing, you want to do stool for over and cyst. And again, what do we call this thing?
CBC.
There is one
Yeah,
investigation I'm forgetting.
CBC.
CBC.
Yes.
Hey, you are forgetting CBC. Okay.
Yes, full hemogram. You do full hemogram. What do you want to check in full hemogram? You want to check for infection, because we were saying that there's a part where you need to treat for infection. You want to check for the HB kikuwa low. Then there was some time I was reading some way back that this child is also likely to have thrombocytopenia. I don't know what is the rationale behind it, but we'll find out before COC. Thank you.
Thank you very much. Yeah, you check for the CBC, you check for the WBC, the HB, and in case because yeah, you check for the other things in the CBC to check if there is thrombocytopenia. You rule out all those other things that can possibilities. Then you see it's very good. You talked about you check for the electrolyte, calcium, magnesium, phosphate, and so on. And then urinalysis. Urinalysis you can check because these children sometimes they do most of them have UTIs. So you check for the urinalysis for UTI. And then I think with those investigations we are good to go. You can react so that you move to the next question. Next question. Thank you. Then we have next question is what is refeeding syndrome and which 3 electrolyte will you monitor to prevent it? Yes, blood culture. We have forgotten that one. It goes along with the CBC to be able to know the blood culture is for specificity and whatever, and also for resistance. Who will take up this question? Refeeding syndrome. Which 3 electrolyte? Do we have Dr. Newton in the house? Or Alvin, if you are ready, you can take us through the refeeding syndrome and the electrolyte you are going to check so that you prevent it.
So just to say I'm not chani jaribu. So refeeding syndrome, as I know, is a medical condition, a fatal medical condition that occurs when these children with some are given their foods too fast. I can say you are starting feeding them too fast. Remember, this child amekuwa na hypoglycemia, amekuwa na ako wasted, definitely means for some time this child has not been getting enough food. So the body will resolve to breaking the muscles for energy. So which means there was no glucose there, hypoglycemia of course is there. So the body resolved to breaking glucose for energy. Definitely there kukakuwa na a shift in insulin, kukakuwa na decline in insulin production because now there's no glucose, so the body is not producing enough insulin. So restarting the feeds so aggressively, let's say tumeanza feeds haraka sana, which means the body now it will shift back from, okay, let me start, Edwin. Refeeding syndrome is a fatal medical condition that occurs when we start feeding these children with some too fast. Remember, their bodies have been used for kumekuwa na some, the body is used to low glucose level.
Starvation.
Yeah, the body of the patient kumekuwa na low glucose level. So their bodies not producing insulin. The insulin level is too low. Now there is no glucose to use. The muscles are being broken down and something like that. Now starting the feeds too fast, which means what? The body, if it detects there's some foods in the body, now the glucose will rise. So the insulin has to be produced. When the insulin is produced in a large amount, of course, we know insulin, what insulin does. It's a powerful potassium shifter. It will shift potassium into the cells. When the potassium is shifted from the blood to the cells, then we are now concerned about potassium. Potassium goes in hand with, I think, magnesium and some phosphorus. So those 3 electrolytes will be keen on them: potassium, phosphorus, and magnesium. Now the symptoms this child will present in refeeding syndrome, it acquires the symptoms of hypokalemia. And we know hypokalemia is very dangerous with the heart arrhythmias and stuff. Yeah, I think that is a nutshell of refeeding syndrome.
Thank you very much. That's well elaborated. The pathophysiology has been clear, and that one you have related with your physiology. So he has mentioned all that one that is required from starvation to now feeding to leading to electrolytes shift with the relation to insulin, and you monitor potassium, magnesium, and phosphate, and also calcium. So that is well done. I don't have much to add, but to absorb the knowledge. Let's now go to the next question. Write the prescription for F75 for this child for the first 24 hours, including volume and frequency. Now remember, this is F75 we talked about on feeding for the catch-up growth. For stabilization, I mean, not catch-up growth. For the stabilization, use F75. Now, as a clinician, when you are prescribing F75, remember our child is how many kg? 7.2 kg. So, what does the WHO recommend? It recommends us to use 130 ml per kg per day. So, meaning the child is 7.2 kg. You can use calculators on your side. This child is 7.2 kg. So if you multiply by 130, so 130 ml, you get 936 ml per day. Are you there? You can react. I've said our child is 7.2 kg. Then we are using F75 to stabilize this child. So we are prescribing. So you use 130 ml per kg per day. So you calculate that. It will give you, take 7.2 by 130, you get 936 ml per day. But now remember, how many times should a child feed per day? 8 times, you know? Now, if you want to get after 3 hours, how many feeds will this child be taking? You get the total feeds that is required in a day. That is 130 by weight, which is 936, divided by 8, so that you get, after 3 hours, this child will be taking at which amount? Now, that one will be like 936 over 8, that is 117 ml per after 3 hours via cup or ng. Another thing that you need to know, if the child is able to breastfeed, continue breastfeeding, and no other feed should be given. Remember also you are interchanging with Risomol in case of rehydration. Then how do you transition to F100? Remember these are F100 and F75 are ready to use, RUTF, ready to use. You can complete that. Ready use. What is it?
Use therapeutic.
Ready to use. Thank you. Ready to use therapeutic food. So the criteria of transition is when appetite returns, edema has reduced, no IV line, clinically improved child. It's usually mostly after 2 days or when the appetite test, when the child has passed the appetite test. Now, when the appetite returns, there is no edema, the child has clinically improved, is when you transition now. Now, it shows, in short, when the child has now become stable. Because F75, you are stabilizing the child. Now, for the catch-up growth, now we continue with F100. How do you give F100? You give F100 130 ml per kg, as same as to F75. Then increase it to 200 ml per kg in rehabilitation phase. Rehabilitation is after even discharge. Transition gradually, 3 days, replace F75 with F100. So you don't just transition immediately from F75 to F100. You do it gradually, you know. Within 3 days, then you replace. Meaning you will be interchanging, then you just now decide to go with F100. As a clinician, you will be helped in the practical. There are a lot of nutritionists in the hospital. You'll work together with them to balance these things. So that is about prescription of F75. I don't know if you are together, you can react, or if you have an addition point on prescription of F75, you can. That is good. Now somebody now is going to take us through the last question. We're talking about 3 complications in the next 48 hours. Which 3 complications are you worried about in the next 3 hours? We talked about them. Let us just mention them. Who's ready? Alimi. Hey, Ali Mohammed. Here you must give us one. You can't go quiet with knowledge. You want that knowledge of yours. Alin Mohammed, are you getting me? Thank you, Alvin. The feeding syndrome, which was well explained, the pathophysiology. I love the pathophysiology of the feeding syndrome. Harriet. Hypothermia, good. Hypoglycemia, septic shock, sepsis is another complication. And then renal failure, good. Acute renal failure, indeed. Somebody talked about heart failure. Yes, because heart failure can be due to just electrolyte imbalance. It can cause heart failure haraka sana. The feeding syndrome, good. Anemia, yes, you've talked about it. Now, that is well done with the complication and with all cases with malnutrition. But now, counseling. I want us also to be active in the chat box. What will you counsel? What will you tell the mother? Alvin had talked initially about the discharge. Discharging a stable child now. As a clinician, what are you going to counsel this mother on? I'll start with family planning. As Benjamin, I'll say that this mother should be counseled on family planning because it's really one of the risk factors or the predisposing factors. If there is no family planning, kuna watu let me use Kiswahili, unafatanisha mtoto bana, huyu mwingine. So the other day when I was in Busia, mtoto ako 1 year ako na hiyo SAM, alafu mama pia mwenye anamlea ako na mimba na ako ward. So family planning is important. As me, as Benjamin, I support that. Assess the no, just advise the mother. Assess, you have talked about, let me read it all. Yes, keep points coming, keep points coming. What are you going to advise? Because it's very important. Otherwise, this mother will come back with that malnutrition. Let me go to the chat box. Assess the socioeconomic status and advise accordingly. Very well. What if the mother doesn't have money? So will you give him money? As a clinician, is it good to give patient money? That's the way. Yes. Thank you. Advise accordingly. You tell the mother to go to the governor. There is some help that this mother can get. Those mothers from Uganda mostly who are presenting at Busia with malnutrition, it's a problem to advise them. Advice on balanced diet, good. Like our child was 18 months. There is something you guys I'm waiting for you to tell me. Hygiene, good. To prevent UTIs. You're forgetting something that you usually do it for 6 months. Vaccines, thank you. Psychological stimulation, talking, play, and interact with the child. Yeah. The mother should not just leave the child like this child was brought by other people in this world. EBF, but ours is 18 months. Wow. Actually, I was not getting this mathematics clearly. 18 months and 6 months, which one is larger? 18 months is larger. Ni kama nalala. And the mother is already pregnant. Hey, sure. The mother is already pregnant, so we don't advise on. Okay, you advise on the mother to monitor the growth, deworming, vitamin A. You talked about immunization, social life. SHA. Nowadays we talk of SHA. Refer to with social worker. Return immediately if danger sign appear. Which danger sign? Can you list them there? At least 4. List 4 danger signs. Nutrition, education with locally available foods. I think you're good. You're talking the mother is already pregnant. So what should the mother do? Terminate the pregnancy. Because already one child has malnutrition.
This was on the point of you suggesting breastfeeding. So Edwin was just saying, how can the child still breastfeed and the mother is already pregnant?
Mother already got new pregnancy. But for you to breastfeed, it just depends. Is the milk still coming out? Ama
Sasa unataka
si hata
kunyonyesha na
wanaume
mdomo yako.
wananyonya. Yes.
I think there is a point ikifika with pregnancy, I think from the second trimester or third trimester you don't breastfeed. Kuna
Yeah.
some weeks if you are breastfeeding, yeah, it's allowed. You can be breastfeeding and still be pregnant, but kuna certain cutoff, kuna time ikifika you don't continue to breastfeed. I'm not sure of the timing, but I think somewhere from the third trimester you don't, because
Yeah,
that
but
time
this
the colostrum of the upcoming baby is starting to be made, so you don't take the other one afai kuchukua the colostrum of the other one.
but is this when somebody is pregnant can start having milk secretion because the breasts are getting ready for their work? Is it possible?
No, no, it's not possible. Reason being, you see, for breast, okay, the milk will be there, the breast will be ready, but milk outlet will not be there. For that milk to come out, there must be stimulation by the baby. There must be the reflex of oxytocin, you understand, so that now the gallbladder cells of the breast can start now squeezing the milk out. That's why there's a age where, as Alvin was saying, the milk cannot come out because that oxytocin level has been suppressed kidogo, because sijui kama una get.
I'm getting you. You know why I asked that question? Because last time I was in the hospital, I had a mother who was miscarriage at 4 months, but now the milk was just coming out after that miscarriage. The milk was just ni kama tu yani, ni kama maziwa inatoka tu yenyewe.
Yes,
Is
for
it really?
all miscarriage mothers, all miscarriage mothers wanakuanga na hiyo nini, wanakuanga na hiyo prolactinemia. That's why huwa wanapewa bromocriptine, because okay, ndo hiyo Alvin amesema hapo, for that trimester mtoto nini, mama oxytocin ikikua inaweza inaweza induce labor before ifike time yake. So okay, venye tu nilikuwa nakuelezea, for all mothers wenye wamekuwa na hiyo, wametoa mtoto kwa first semester, second trimester, ama ikwetu hata third trimester, but mtoto ashatoka, the autoregulatory mechanism ni mwili inajua mtoto amezaliwa, the mtoto need to be fed, but there is hormonal physiology behind it. So utapata most of the mamas wenye wamefanya abortion, wa milk yao inatoka, so wao wana prescribiwa bromocriptine to counteract that.
Okay, thank you. But just a correction. Si wote wanatoa, zingine zinatoka zenyewe. Zingine zinatoka zenyewe, lakini wengi wanatoa. Mungu awasaidie. Haya, I think
Ingine
kwa
manzungu
hayo
ndiye anatoa.
mimi hizo vitu siwezi jaribu, ama SDA. Kwa hayo yote na kwa ufupi na urefu, I think time is much gone. So when do you guys suggest we have tomorrow discussion? I think we can push the time mbele kidogo, because we'll be having a rich I think Asman alikuwa anasema ako na electricity imepotea kidogo, anaweza to take through RH in the morning and kama hatakuwa available pia tutajaribu tuone, because nilikuwa nataka niweke like 7 am. Is it okay?
Yeah.
So if Asman will not be ready, kindly just be ready. Any of you can just lead RH. We can Alvin Okuma, I think I can add you to the part of RH. Let us not waste time. If somebody is not there, there's no need for postponing because the date is 17th and we are just counting 1 week to exam. So we need to sharpen one another. I tried reading alone, I just slept. Okay, okay, Alvin. I'll try, but I know from 7 might be busy. But we'll try. Whoever will be in the meeting, we can give Millicent a chance. Today, the concert has not attended. Okay, but we have any. I think now, if you meet any culprit on malnutrition, you are able to stone this culprit up to death. Yeah. So there's no worry on malnutrition. Get to Paeds. I think among the 100 MCQ lazima tu kutakuwa na malnutrition jamii. So hiyo unapita nayo kama mswaki. Shamaliza. Malnutrition you are good. We were to talk about malaria, but it's an assignment now. Malaria is common question zinauliza, go and find out. Like the first line treatment. Malaria is a common thing, but hizo maswali pia zinaweza kuchanganya kidogo. Try and just find out the common question. Starting from the classification, signs of severe malaria, hizo ndio zinaulizwa. Complication, first line treatment of severe malaria, how do you manage those complications? Like pia kuna hypoglycemia huko. So those things are the same, they repeat themselves. That is malaria is simple. We want to talk about meningitis. So go find out what is this meningitis. It's infection. Yeah. This meningitis, they like asking about the causative organism. The last essay I saw, it was asking about mention 3 causative organisms of meningitis. Then another question that will be asked is the investigation. And on investigation, they are too specific. They really want you to know. If you are talking about your diagnosis being acute bacterial meningitis or viral meningitis, on your investigation, LP, how will you differentiate? The COC is targeting, how will you differentiate bacterial and viral, you know? And then somebody is going to tell us that. How will you differentiate bacterial and viral after doing an LP and culture analysis, CSF analysis, I mean? How will you differentiate? And even the contraindication for LP. And then on meningitis, the clinical signs. Signs of meningism. That is a question that will always come. The 3 signs, you know. Somebody is going to talk about that one. Me, I'll talk about treatment. If it is bacterial meningitis, ceftriaxone. If you go to the protocol, it's talking about ceftriaxone, high dose. Then, how do you even cancel the mother if it's on meningitis? The differentials of meningitis, the importance differential of meningitis, bacterial meningitis. They can take you to TB meningitis, but it's mostly question focusing on bacterial and viral meningitis. How do you manage? Now, within a spite of 5 minutes or 10 minutes, we are going to close. But I would like Imela Damaris to pick up on the clinical features of meningitis in children. Just be brief. Say what you know. If the question now COC ku imekuja sahi. Time
Okay,
has been started.
there's fever, stiff neck, convulsions, yeah, an aspect of photophobia, yeah, headache, though watoto sijui kama wanaweza sema. Yeah, I think those ones.
Thank you. Dori, has she exhausted? We have 4 minutes. Thank you,
I have
Doria.
4 minutes.
No, you are done. I was asking about Dori to add up. Now, on investigation classification between bacterial and viral. Millicent, what do you have to say on that? CCF analysis, how is it different, bacterial and viral? Do you have something? Okay, for the bacterial, there is proteins. The glucose is low. There is what? I've forgotten. Neutrophilia, that is for the bacterial. Then clinically turbid. Then for the viral, leukocytosis, glucose normal, high ICP, raised ICP. Those are some of the things that you need to know. Then management of viral is mostly supportive, fluids, supportive management, like analgesics, paracetamol. Viral lymphocytes are high, good. Then on canine sign, you need to know what is this canine sign. Find out canine sign and Brunzinck sign are the meningeal. Those are signs of meningeal irritations. Importance differentials in the chat box. We have 2 minutes. Importance differentials of meningitis. We have cerebral malaria. Another one. We have sepsis. Another one. Me, I'm done. Things that affect the CNS. You can talk of hepatic encephalopathy. Neonatal sepsis. When I'm talking about sepsis. Clinically, when you're looking for a child with meningitis, you can check the child is below 18 months. You can check the anterior fontanelle. Is it bulging? That's a clear indication. How is the child AVPU at you? You be very careful on that. The other day on Paeds, we'll be talking about convulsion and management. So you guys, I think our time, we want to just finish. It has been a great session and we have gained a lot. On malaria, find out more. On meningitis, find out more on the we have given out what is mostly asked. We are going on what is mostly asked. Hatuguzi tu kila kitu. So tomorrow, get ready for a rage. I think Asman will be taking us through emergency. If not Asman, I'll try take you. If I get caught up, somebody picks on, we go on. Tomorrow is Thursday. Then in the evening, we'll be interacting. If it is still that RH, we'll still interact on it. So I think it will mostly be on obstetric emergencies. I want to tell Asman. So get ready on obstetric emergencies tomorrow. Have a blessed night, and may God enable us to pass through this journey that we have started. And we are ending on 17th. From 17th, no more exams. Let us just sacrifice. Thank you. Bye.